Hello, everyone, and thank you so much for having me at this STAR Conference 2025. My name is Smit, and I will tell you today about this paper which I wrote a couple of years ago, The Future of Artificial Intelligence in the Intensive Care Unit. Just shortly about me, so my background is engineering. Last couple of years I did a PhD at the Intensive Care Department of the Erasmus Medical Center in Rotterdam, the Netherlands. Currently, I'm working as a postdoctoral researcher at the Department of Data Science in Radboud University in Nijmegen, the Netherlands. So this paper, The Future of Artificial Intelligence, Moving from Predictive to Actionable AI, published in Intensive Care Medicine, is all about this difference between predictive and actionable AI. So to introduce you, a lot has been written, of course, about AI. This is a hot topic also in intensive care unit area. And a lot of papers are having this common denominator. So early prediction of circulatory failure or early prediction of sepsis, early diagnosis of bloodstream infections. The common denominator among all these type of studies is that they predict a certain adverse outcome in the future. So the question they try to answer is what will happen. And the model used, if it would be used in clinical practice, could look something like this. So on a computer screen, in a warning saying, hey, be aware, this patient may have a septic sepsis very soon. And AI could warn a doctor. So the limitation here is what it cannot do is it cannot guide a ICU clinician what to do to prevent or treat this adverse outcome. So it cannot help the doctor to say what to do to prevent the sepsis or treat it. On the other hand, actionable AI is another type of AI which tries to answer this question, this exact question, what to do. So in real life, it could look something like this, that it advises a certain specific treatment, like administering IV fluids, which the AI then predicted to be good for this specific patient. So this is great. So it's not impossible. It's just a different type of AI. But the question is, of course, why is the left type of AI not able to do this? So why is predictive AI, predicting outcomes in the future, not being able to advise actions? It has all to do with these biases. To start, for example, confounding bias. So it's a very silly example here. So let's say that there is people drinking a lot of alcohol at a party, and drinking a lot of alcohol could cause a headache. The next morning, it could also cause if you drink very much, to go to sleep to bed with your shoes still on. Now, if you would collect data from these people and then see that those who got a headache also typically were the ones who went to sleep with their shoes on, we see an association between these two things. So if we just naively look at this data, we may think that we should remove shoes from sleeping people to prevent their headache the next morning, which is, of course, not true. So this is a bit of a silly example, but in medical data, similar things could happen. So let's say that there's a lot of patients which are very severely ill, and there's also patients which get most of the palliative care consults. Now, if we would just naively look at this data, we could see the association between palliative care consults and higher mortality. Just those who had these consults also have higher mortality. And we could naively think that if we would remove these palliative care consults, or stop those, for example, that we could lower mortality, which is, of course, not true. And this is still a bit of a silly example. It could be something way more subtle, like a certain laboratory biomarker, which is higher, associated with higher mortality, and still cannot tell us whether acting on it would improve outcome. So this is a causal question. So this is stupid, right? We cannot say we stop palliative care consults to lower mortality. So the mantra here is that associations, which we see in the data, do not necessarily imply causation. That's what's all about. This is where it's all about for actionable AI. Actionable AI try to make causal inferences, so causal estimations of causal effects. So that's what actionable AI, in contrast to predictive AI, tries to do. The question is, of course, how? Because let's go back to this silly example. We are suffering from these biases when we're looking at observational data. So let's simplify things a bit. So let's forget this specific example and say that there are certain confounders in data sets. There is certain treatment or action in which we are interested. So say we want to know the treatment effect of giving IV fluids, and we want to know what its effect is on the patient's outcome. Now, in a randomized trial, this is fixed due to the randomization. So because of this randomization, all that the treatment or action depends on, everything that decides whether or not this patient is treated or not, is the flipping of a coin, is the randomization, which makes that the confounders are blocked in a way. So if we are not in the luxury to perform a randomized trial, we need to come up with something else. And that's where AI could come in. So with certain strategies, such as inverse probability of treatment weighting, we could adjust for these confounders. So you could say that applying these type of methods is using a certain data model, AI model, if you will, to be able to predict the treatment effect of a certain treatment on the patient outcome, adjusting for the confounders in your data set. So what we call this is a target trial emulation. And this is kind of like just how you call the recipe. It's a good thought experiment. So if you have an observational data set, then you can imagine the ideal RCT that you would like to do. So let's say you want to know the certain treatment effect of giving IV fluids or certain fluid management therapy. We adjust for biases, so for the confounders, for example, using this IPTW models. And in this way, we emulate the ideal trial that we would have liked to be done if the resources would have been there. This is what we then call a target trial emulation. So this is just published a couple of days ago, the newest guidelines on performing and also reporting about your target trial emulation, published in the BMJ. So this is all about predicting average effects of certain treatments using data models, so using AI, if you will. But this goes way back, right? So this is a paper from 2000, and these people used this IPTW data model to predict the causal effect of this drug for HIV-positive men using observational data. So these people did not do an RCT, but they were able, using these AI models, to predict the average treatment effect of this drug. So you could say that they were using this AI already in 2000, right? So now let's go to a different topic, heterogeneity of treatment effect. So this is specifically interesting for the intensive care unit. Why? The intensive care is notorious for their bad track record of RCTs. RCTs are typically negative in the ICU, and a lot of people think it's due to the heterogeneity of the ICU population. Just the ICU population is too broad, too heterogeneous, that we can find good average treatment effects. So what if we want an AI model that does not predict the average effect of a certain treatment, but predicts this for individuals? So given a individual patient's characteristics, predict the treatment effect of a certain drug or procedure. So let's introduce this with a certain funny story. So this is Bill Wellington. He was a teammate of Michael Jordan at the Chicago Bulls back in '95. And he had this famous quote. So after a certain game, he quoted, Michael and I combined for 57 points. And he was right. They combined indeed for 57 points. Michael had 55 and Bill scored 2. Together, they scored 57 points, which is an incredible number for two players, right? But he did not contribute that much to it. Similar things could happen in randomized controlled trials. Certain patients could benefit from a certain treatment, while others do not benefit at all or are even harmed. So you could say that certain patient subgroups represent Michael here, which cause the positive effect of a certain randomized trial, while other patient groups represent Bill here, which do not benefit only slightly, or are even harmed by the treatment effect. The trick is, of course, that our AI model can point out which patients are those who benefit most, such that we can further personalize our medical treatment. So this is another problem, and we just need other type of AI models to do this, rather than the IPTW estimator that I talked about before. To give you an example of this type of things in a real world example, I'll tell you about this study that we have been working on with many other researchers, which is a study on the causal effect of corticosteroids in community-acquired pneumonia. So this is a question which has been there for decades. Should or should we not treat CAP, so community-acquired pneumonia patients, with corticosteroids? Now, we developed an AI model that predicts this for individual patients. So we do not want to know what's the average effect, but given a certain CAP patient, given their characteristics, will it benefit from corticosteroid treatment? So you see, like, the track record here is very similar to the ICU world, right? A lot of negative trials, some trend to benefit, some trend to harm. So it's really a mix. And this was our goal, to build an AI model that could predict for individual patients, based on their characteristics, how much benefit or how much harm they will have from corticosteroids. So this is kind of how it worked. So this effect model would take in baseline characteristics of the CAP patient, and it would predict the future twice. So it would predict mortality risk for these patients, given that they would be treated with corticosteroids, and given that they will not be given by corticosteroids. So this is twice a prediction of the future. And there is your treatment effect prediction given no steroids and given steroids. So the difference between these two predictions, that's what we call the individualized treatment effect. So what happened here is that this model predicted the future twice, predicts mortality risk twice, given treatment and no treatment. And the difference between it is what we then call the prediction of treatment effect of corticosteroids. Putting this on a continuous scale, we could, of course, make two subgroups of these patients. And what we then did in unseen randomized trials, we subgrouped the patients based on our model, our AI model predictions. And what we saw was that there where the model did not predict benefit from corticosteroids, we observed no benefit from corticosteroids, so an odds ratio of 1. And in the subgroup where we predicted benefit, so the other 630 patients, we saw an enormous benefit. So mortality reduction, odds ratio of 0.45 from corticosteroids. So this way you can see that how powerful these methods can be, where we predict benefit for certain patient subgroups and we also observe it in other randomized trial data. So this type of techniques, of course, are not stick to the specific example of CAP and corticosteroids. We are at the ICU conference today, right? So for all kinds of treatments, it could be fluid management, it can be vasopressors, whatever. You can use these type of techniques to train models to predict treatment effect of these treatments, specifically based on patient characteristics. So I will not go into too much detail here. I do not have the time for it. But there are a lot of different techniques people can use to fit these type of models. So in our specific example of corticosteroids, we used a regression-based model. There are also a whole class of models, what we call meta-learners, which are kind of learning recipes. So you can plug in your favorite machine learning model, let's say a random forest, and you can follow a certain recipe to make these predictions for individuals. Also, you're probably familiar with the random forest, which is a very well-known machine learning model. Causal forest is the causal equivalent of it. So it predicts treatment effects based on baseline individuals on a very flexible way in the same tree-based estimations as random forest does. And the last bullet is foundation models. This is a bit of the future. So this presentation is about the future of the intensive care. So I also talk a bit about the future. So the difference is that these are all still supervised AI models. So they are just a certain method, and this method needs to be fed with data. So it needs patient data, who was treated with treatment, who was not treated with the treatment, who had the outcome, so who had mortality, for example, who had not. The model trains, and then it can make its predictions in new individuals. This is not how it works with foundation models. So I don't know. I'm not sure if everyone knows what foundation model is. It's the umbrella term of models such as ChatGPT. So the question is, these gigantic foundation models, which do not work in a supervised way, which are much bigger, which work, is there a future where we could just ask ChatGPT, given certain characteristics, will this patient benefit from corticosteroids? Like, could we just skip our whole paper here, not building the model, but just use a certain large language model to do these predictions? Well, the answer is at least not yet. So there is a lot of research also on this going on, and who knows that at some point we also are able to train foundation models which do not even need to be trained with specific data from a specific treatment or a specific patient population, but just can be queried to ask whether this patient will benefit from my treatment where I'm interested in. So that's a bit of a look into the future. There are really papers going on working on that. The take-home messages is to advise clinicians on what to do to prevent or treat. We need actionable AI. Actionable AI needs to predict treatment effects, and to predict treatment effects, we need to adjust for biases such as confounding. Predicting average effects is what we call a target trial emulation, and if the treatment effect is heterogeneous, which is often the case in the ICU, we need AI to predict individualized treatment effects. Thank you very much for having me. Please make sure to read this paper, which is a great summary of what I've been talking about today. And if you have any questions, please reach me at this email address. Thank you so much.